will really focus on investigations of acute kidney injury. And I think it's quite an important topic. It's very important when we talk about acute kidney injury that we remember acute kidney injury is actually a syndrome. It's not a diagnosis. And it's a syndrome which has multiple different etiologies. It's also important to remind ourselves that the kidneys are extremely vulnerable. They're very vulnerable to failing. And they're vulnerable because of their complex structure. So they are very vascular. They consist of up to 1 million nephrons. They have a very complex tubular and microvascular regulation. And even each glomerulus, as it stands here, isn't just a loop of capillaries. They are very complex units within the kidneys. And even when you look at them in more detail, they can only function if all these different cells work together and are functional. Now, the kidneys receive 20% of our cardiac output, and as such, they are very vulnerable to hemodynamic problems and also any other exposures, whether they are nephrotoxins, any other inflammatory cytokines, any other metabolic waste products. And as such, it's not surprising that the kidneys are often affected in any type of critical illness. So acute kidney injury, as I said, is not a diagnosis. It's just a term used to describe impaired renal function. And by convention, we diagnose it using serum creatinine or urine output, because these are the best markers we've got available, and these are traditional markers which are available everywhere. By consensus, we've defined acute kidney injury by a rise in creatinine by 26.4 micromoles in 48 hours or less, or a fall in urine output. And as you know, the KDIGO classification then asks us to determine 3 different stages based on the rise in creatinine and fall in urine output. Now, I put this up just really as a reminder to say that patients can have impaired renal function without any of these changes. And at the same time, we may have patients who have a change in either urine output or creatinine without an actual deterioration in renal function. And that's because creatinine and urine output both are not renal specific, and they can change or not change in certain particular medical conditions. Just a reminder, creatinine, as I've said, it's not renal specific. It depends on several factors and several acute and chronic conditions. Creatinine is the waste product of creatine. And as you know, creatine is an energy reservoir which all our muscles need, our skeletal muscles. Creatine is metabolized. It's a product of arginine and glycine, mainly produced in the liver, but also a little bit is produced in the pancreas, and a little small amount is produced in a healthy liver, in the healthy kidney, sorry. Once produced, creatine gets released into the systemic circulation. There may also be some additional creatine from red meat, and the creatine will then serve as an energy reservoir and will serve to help the muscles producing energy and contracting. And as a waste product, as a metabolic waste product of creatine, creatinine is then secreted and subsequently cleared in the kidneys. So as you can immediately see, the serum creatinine in our blood depends clearly on renal function, but not just that. There are many other factors which will determine and affect a plasma level of creatinine. I've listed some of them here. So clearly in patients with liver disease or in patients with sepsis, there may be a delay in creatinine rise. And then there may be other conditions, for instance, patients with jaundice, where you can't interpret the creatinine. And then there may be patients who have a creatinine rise without any change in renal function. They may have a creatinine rise just as a result of interaction with certain drugs, like cimetidine. And the same applies to urine output. When you've got a reduced urine output, it's important to distinguish whether it's actually an important pathological degree of oliguria, or whether it's physiological oliguria, or a change in urine output as a result of medications. So the traditional markers to say whether patients have acute kidney injury or not are not renal specific, and therefore require us to interpret them properly and appropriately in the right context. But once you've decided that somebody may have acute kidney injury and you believe the change in creatinine is real, and or the change in urine output is real and a true reflection of a change in renal function, then it's clearly important to identify the underlying etiology. And again, here it's important to remember that a lot of patients, particularly in the ICU, may have several reasons for acute kidney injury. They may have several reasons why their kidneys are deteriorating, kidney function is deteriorating. As a reminder, in the AKI study, one of the largest observational studies looking at acute kidney injury in sick patients, sepsis was one of the most common causes, followed by hypovolemia and drugs. But there was quite a lot of overlap, and there were quite a lot of patients who had sepsis-induced acute kidney injury plus exposure to some various drugs. So sometimes it may not be possible to identify the exact main reason. Sometimes it's possible that patients have several reasons and causes for acute kidney injury. But back to the title, which was, how do you investigate acute kidney injury? What's a diagnostic workup? I put it to you, if you decide that somebody truly has acute kidney injury, that the rise in creatinine is a reflection of renal function, their urine output, their oliguria is a reflection of an impaired renal deterioration in renal function, then it's important to do some basic tests. And I think, certainly this is what we teach in the UK, the basic things include a full blood count, a urine dipstick, and the consideration of a renal ultrasound to exclude obstruction, if obstruction is a possibility. And then the rest really depends on the clinical context, the clinical signs of the patient, the clinical setting, and the trajectory. And once hypovolemia and obstruction are excluded, then I think it is, again, up to the clinician to come up with a good differential diagnosis depending on the clinical signs and settings, and determine what the most likely diagnosis or the most likely cause of acute kidney injury may be. And clearly, in somebody who's got acute kidney injury after having done a marathon and taken some non-steroidals, where rhabdomyolysis is a strong possibility, the tests will be different from somebody who presents unwell with multi-system signs and a funny rash, where vasculitis may be a possibility. And so these are just potential diagnostic or investigations which you may want to do, really depending on what you think is the most likely cause. Because I don't think there's no system in the world, no health system, where you can afford to do all these tests for everybody. And it shouldn't be like that. We should use, with acute kidney injury, we should use our medical knowledge and apply it to the patient in front of us and individualize the diagnostic investigations. Just a few words about urine microscopy, because as you may have noticed, it was on the first slide. I personally strongly believe that urine microscopy is still a very valid tool. Although I believe it, I don't do it anymore. I used to do urine microscopy regularly. It's an old traditional tool which is still being applied in some hospitals. And when done properly by experts, by people who do it routinely, regularly, who have a system in place to look at fresh urine, freshly spun, and having an appropriate microscope and the expertise, then I think the urine microscopy can give us valid information. It's a bit like a liquid biopsy. And with expertise and experience, people can certainly either exclude certain conditions. So if you have a completely bland urine without any cells, it's unlikely that this person has glomerulonephritis. Similarly, if you see lots of bacteria in an appropriately sampled fresh urine sample, then urine pyelonephritis or an infection is more likely and is higher on the cards. So a simple test doesn't cost much, and still we don't use it very often, and I don't use it anymore because it has these limitations, and you need it needs to be fresh, it needs to be freshly spun, and you need the appropriate expertise. And sadly, certainly in the UK, we are no longer training and educating trainees in this, which I think is still an important skill. But I believe that there are other hospitals, countries, where urine microscopy is still being performed. Certainly some studies in the literature looking at the value of urine microscopy, not necessarily as a diagnostic tool, but as an additional tool in the assessment of acute kidney injury. There's a study which was performed by Sean Backshaw and Professor Belomo in Australia, and they looked at urine microscopy in patients with acute kidney injury and distinguished between those with septic AKI versus non-septic AKI, and then performed an immediate urine microscopy within 4 hours of sampling. And depending on the presence of granular casts and the presence of renal tubular cells, the urine was scored. And essentially what they found is that patients with septic AKI had a higher score, so they had more granular casts and more tubular cells. They also had a higher risk of progressing, but they were also sicker. So in this observational study, the urine microscopy essentially served as a prediction marker, a marker to identify patients who were likely to progress and likely to need renal replacement therapy. Having said all this, they were also the group of patients who were sicker, in whom the severity of sickness scores were higher, and there was already clinical suspicion of them deteriorating and having a higher risk of deteriorating. So to date, I've not found a single study where the urine microscopy in the ICU setting helped making the diagnosis and identifying the exact underlying etiology. It's been used, like in this study, as a marker of severity, a marker to prognosticate. Now, urine electrolytes are also another tool which are sometimes used by people to diagnose and investigate acute kidney injury. And obviously chapters in most textbooks about the value of fractional excretion of sodium or fractional excretion of urea. I personally don't use it anymore as a diagnostic tool. It's advocated and may be useful in cases where you want to distinguish between functional AKI, which used to be called pre-renal AKI, and tubular injury. And I don't find it useful because the majority of patients who I look after have many other factors which confound the urinary electrolyte excretion and confound sodium and urea excretion. And the typical ones are obviously the use of diuretics and CKD. However, there are people who measure urine electrolytes regularly and find them very useful, especially when measured every day. And they use the serial information, the serial urine electrolyte results, as results to give them some trends about either deterioration of tubular function or improvement. we don't use them anymore, but to investigate acute kidney injury, to identify the underlying etiology. However, I still think they have a role, as I've already said, either as a serial test, or if you want to diagnose an underlying electrolyte or acid-base disorder. So in cases where you may be concerned about renal tubular acidosis or investigate an unexplained metabolic acidosis, I think urinary electrolytes still have a very important role. Finally, the renal biopsy, and it's certainly a tool or investigation which is frequently performed in renal units, but not very frequently done in the intensive care unit, and probably not as often performed as it should be in critically ill patients. Can be done either percutaneously or via transjugular approach. And clearly, if you're faced with somebody with a rash like this one, or funny spots in peripheral limbs, doing a renal biopsy can be extremely helpful, because you may be concerned about an underlying vasculitis, which may require treatment with cyclophosphamide or other immunosuppressants. And you may just want to be sure that you're truly giving these strong medications for a good reason. And in cases like that, a renal biopsy can be very diagnostic and confirmatory. You may find a biopsy or a glomerulus, as shown here on the right-hand side, where the glomerulus is completely destroyed by inflammatory cells and inflammatory tissues. And in fact, the capillaries have completely gone. The glomerulus has been destroyed. There's no patent lumen anymore. And in cases like this, only a renal biopsy can make the confirmatory diagnosis and justify the use of cyclophosphamide or other immunosuppressants. So it's a very important tool, underutilized in critically ill patients due to concern about potential bleeding. And I think the risk of bleeding shouldn't be underestimated. If you do a CT scan routinely in everybody who's had a renal biopsy, then more than 80% of patients will have a small perirenal hematoma, and a small proportion will have a major bleed. It's an invasive procedure. It needs to be done by skilled people. And it may also give you some additional information, not only about the underlying diagnosis, but also the background state of kidneys. So evidence of pre-existing chronic kidney disease or severe fibrosis, which may alter and change your plans to give cyclophosphamide. But although it's diagnostic, it is only, you only have a look at a small, tiny piece of kidney tissue, and there's obviously a risk of sampling error. Bleeding is the main reason, I think, why patients in the intensive care unit don't have renal biopsies, and why we are reluctant to perform percutaneous biopsies. But there are other approaches, as I've already said, and here's a paper by my co-chair highlighting the value of transjugular renal biopsies, where obviously the risk of bleeding is much lower, and if they bleed into the vascular system. So these are the common traditional tests which people use. I put it to you, they need to be individualized based on the individual clinical setting. There's obviously hope that things will improve, that we find more and better tests in the future. And there's a lot of hope that these new biomarkers, which obviously are proteins or substances released from different parts of the kidney in response to different injuries, will at some point also help us diagnosing acute kidney injury and finding the underlying cause. But so far, none of them have been used as a diagnostic tool, but they may well do so in the future. So in summary, acute kidney injury is a syndrome and often multifactorial. It's important to try to identify the underlying cause, because it may guide your management. The workup needs to be individualized and directed based on the clinical condition and clinical setting. And also the intensity, in my opinion, depends on the trajectory of renal function and your therapeutic options. If patients' creatinine is high but improves very quickly within 48 hours, you may hold off and not do a full renal and immunological screen because it's so unlikely that they have severe underlying glomerular disease or an autoimmune disease. And in future, we may have more tests, including novel biomarkers. Thank you very much.